Hello, I'm Hematologist Oncologist Dr. Tony Talebi. Today we're going to discuss Her2 new positive breast cancer. I have the pleasure of being with Professor Chuck Bogle from University of Miami, Deerfield section. Thank you for being here.
It's my pleasure.
Dr. Bogle, what is Her2 new positive breast cancer?
Her2 is a gene that is present in everybody. Basically, everybody inherits two copies of the gene, one from their mom, one from their dad. And so Her2 has some particular function that is necessary in the body. However, in breast cancer, about 20% of women who develop breast cancer develop an abnormality in this gene whereby they make, instead of 2 copies, 4, 6, 8, 10, 15 copies. When that happens, the normal function of the gene is subverted, and it now becomes what's called an oncogene.
Mm-hmm.
Now, you don't inherit this aberrancy from your mother and father. It's something that happens in the course of the development of the cancer. So that makes it different than the BRCA1 and BRCA2 genes, which are genes that are inherited and can lead to the development of breast cancer. So Her2 new is very different than BRCA1 or BRCA2 in that regard.
I see. So what are some risk factors that predispose one to developing breast cancer, either Her2 new positive or Her2 new negative?
Well, there are a number of risk factors. The first one is age. The older a woman gets, the more predisposed they are to getting breast cancer. Obesity certainly plays a role. Genetics plays a role in a very small fraction of breast cancer as we know it now. Only about 10% of patients are genetically predisposed through BRCA1 or BRCA2. However, we see a lot of families that look as though they should be a BRCA1 or BRCA2 carrier and are not. So somewhere out there is a BRCA3 and a BRCA4, etc. So I think that a much larger percentage of tumors are going to prove to be genetically determined than we currently know.
In your experience, is there a certain population that's more apt to being Her2 new positive than negative, or no?
Not really. From the standpoint of being Her2 new positive or negative, it seems to be relatively random.
Mm-hmm.
From the standpoint of histologic types, in other words, under the microscope, when you look at a tumor, most cancers are found within the ducts of the breast, and a much smaller amount are found in the lobules, about 9% in the lobules, about 80% in the ducts, and then the other 11%, give or take a few, are made up of a number of other types of subtypes. One of the things that is quite clear, and that is that classical lobular carcinoma is almost never Her2 new positive. There is a newly described variant of lobular carcinoma called pleomorphic lobular carcinoma that can become Her2 new positive. And about 30% of those pleomorphic lobulars are Her2 new positive.
I see. So just the Her2 new positivity itself, please explain to our patients what is IHC in FISH?
Basically, these are two different ways of testing for Her2 new. The IHC, or immunohistochemistry, looks at the number of protein molecules of Her2 on the surface of the cell. And in the best of all worlds, there's a very close relationship between what happens in the nucleus of the cell, where the genes reside. The genes then program the proteins. So the more genes you have, the more copies of the protein you should express on the cell surface. And so for immunohistochemistry, it's graded on a 4-point scale: 0, 1 plus, 2 plus, and 3 plus. That's as far as it goes, 3 plus. 3 plus is considered as positive, 0 and 1 plus are considered negative, and 2 plus is considered indeterminate. And about 27% of patients who are 2 plus positive also have amplification of the gene within the nucleus of the cell. About 75 to 80% of patients that are 3 plus positive have gene amplification. And in studies that we just presented in San Antonio last year, we, as well as some other people, have found that even for patients who are 0 or 1 plus positive, about 4% of those are actually FISH positive. So to get back to your other question, what is FISH? Well, the IHC test looks at the protein on the cell surface. And there are a number of ways of looking at the gene copy number within the cell. One is called FISH. It has nothing to do with salmon or halibut. It's called fluorescent in situ hybridization. And there are variations of that. There is also KISH, which is chromogenic in situ hybridization, and SISH, which is silver in situ hybridization. All of these are measuring the number of copies of the gene. And I think that FISH is probably the most reliable of all of those tests, including IHC.
So at what number would a doctor run a FISH test? An IHC of +1, +2, +3?
I actually do it in virtually everyone. Why do I say that? Because if you miss a HER2 positive patient, you're going to deprive them of potentially life-saving drugs. And once we discovered that the 0 and 1 pluses have a 4% false negative rate, we decided, well, we did some math, and if you do the math, there are only 20% of patients who are HER2 positive. So if there are 200,000 women in the United States who develop breast cancer, and there are more than that, we'll use that as a round number. If 20% of those are HER2 positive, 180,000 women are 0 and 1 plus. And if you do the math, 4% of 180,000 turns out to be about 4%. And so that turns out to be about 5,000 to 7,000 women a year. In the United States, 50,000 patients worldwide that are being deprived of HER2 positive drugs.
Very interesting. Now, patients always ask us, when should they seek genetic counseling when they've been diagnosed with HER2 positive breast cancer?
Well, the two are really mutually exclusive. As I said before, being HER2 positive has nothing to do with a hereditary predisposition. So you have to separate out the concept of HER2 from genetic predisposition. There's nothing inherent in being HER2 positive that would lead one to recommend genetic counseling. So you have to go back to the classical ground rules for who should have genetic counseling. You look at in depth at the family history. And if you have 1 or 2 first-degree relatives, certainly if you are of Ashkenazi Jewish background, these are a couple of reasons why one should consider sending a patient for genetic counseling and then genetic testing.
Next question is the family members always want to know, should they have genetic testing?
Genetic testing for a family member should not generally be done without testing the person with the cancer. Because it's the person with the cancer, if they're going to be a gene carrier, they're the ones that will test positive. So then, if you now know that a family member tests positive, then the family should be tested. And what everybody needs to know is that if, let's say, your mom tests positive for HER2, you've got, as a child, a son or a daughter, have a 50% chance of inheriting that gene. So it's not a slam dunk that if your mom has HER2 new positive disease, BRCA positive disease, a genetic carrier, that you will be a carrier. You have a 50-50 chance. That goes for the boys and the girls. There's also a misconception that the gene, BRCA1, BRCA2, which are the ones we know about now, are passed down only through the mother's side of the family. That is not true. It can be passed down through the father's side of the family as well, and that's very important to know.
Let's just take a step back. We'll get into the details of treatments later, but let's just say a woman has gone for a mammogram and they get that frightening call, we see a mass. Just generally speaking, what happens next?
Well, if a patient gets a mammogram and they see something suspicious, the breast imager, the first thing to do is to do other tests. Usually, depending on how suspicious it is, some of these are indeterminate, just a little bit suspicious. You might want to do additional mammographic views, cone down views, magnification views. Ultrasound is frequently done. Sometimes you need to go to MRI in order to be a little bit more certain, not just about the suspicious area, but other areas in that same breast and other areas in the other breast as well.
I see. And let's say a woman does end up getting a biopsy, a needle-guided biopsy, and it does come back positive for cancer. What happens next?
Well, the first thing I do is I look at all of the characteristics of the tumor as it appears under the microscope. You look at the degree of differentiation of the tumor, which means that the grading is grade 1, 2, and 3. Grade 1 looks more like normal breast tissue. Grade 3 is a kind of wild-looking tumor, and grade 2 is obviously intermediate. You look at the grade because that gives you an idea about how rapidly the cells are growing. Grade 1 tumors tend to be slow-growing. Grade 3 tumors tend to be fast-growing. We then want to look at the estrogen and progesterone receptors within the cell. These are determinants of whether or not the tumor is under the hormonal control of the woman's body and therefore amenable to drug therapies that can help. We also want to look at HER2, and most people usually start with FISH, with IHC, and then move on to FISH if they need to. I eventually get to FISH in virtually all of my patients.
I see.
So now you've determined that this biopsy is positive. You know what the biological behavior of it is looking like, and then you have to sit down with the patient. It's usually done with the surgeon, although as a medical oncologist, more and more we frequently are seeing patients earlier and earlier, and we enter into a discussion with the patient about the surgical options, which for the most part are lumpectomy, which is associated with the use of radiation post-operatively, or mastectomy, removal of the breast. Before we do that, if the tumor has some bad characteristics, I would want to do what we would call a metastatic workup beforehand. And there are different ways of doing that. I was just in a conference with a group of my peers, a number of experts, and I was sort of a lone holdout among many very prominent people. I do a PET-CT as a screening test. None of the other people in that room did that. They rely on CAT scans, the chest, abdomen, and pelvis, and a bone scan. And to me, I think PET-CT is still a very good screening test. So in spite of my respect for my peers, I sort of hold my ground. And that's the usual screening test that I will do as a metastatic evaluation to look all over the body, make sure we don't have disease in the bones, the liver, the lungs.
I see. Diet is so important, and it's very often asked about. Are there any diets that can prevent breast cancer? And are there any diets that one should be on once one has been diagnosed with breast cancer?
That's a pretty tough question, really. There have been lots of literature on diet and breast cancer. The one thing that is growing increasingly clear is that obesity can play a major role not only in the development of breast cancer, but also in its rate of progression. It also has prognostic significance on how long people will live. Women who are overweight tend to die of their disease sooner. They tend to develop metastases sooner. However, all that said and done, to me there seems to be a couple of different breast cancers. I'm sure that there are many, and in fact there was a recent article that says that there's probably 10 different forms of breast cancer. I suspect that there are many more than 10. So having said what I'm supposed to say about obesity, my average patient is a 38-year-old athletic vegetarian runner without a family history who says, why me? So there are certainly a lot of asthenic, athletic women who don't drink, don't smoke, vegetarians who will develop breast cancer. We don't know why, but we do know that obesity is definitely a risk factor. As far as a preventive diet, no, I know of none. I know one of my colleagues, Dr. Orlando Silva, feels strongly about different aspects of the diet. He would be somebody that would be interesting to ask about that. Once a patient has developed breast cancer, I would certainly encourage them to be on some type of usually weight reduction program, because once a patient has been diagnosed with breast cancer, almost invariably they gain weight. Whether they are on hormones, whether they are on chemotherapy, whether they are on nothing, they gain weight. Why that is, I really don't know. You know, there are theories that, people think, oh, you've got cancer. They think of concentration camp victims, looking gaunt and wasted. Well, that's not the case with breast cancer. Breast cancer, most of the patients are a bit overweight and would benefit from weight reduction.
How do you deal with the psychosocial aspect of a woman developing breast cancer? Breast is so important for a woman. That's her source of, giving nutrition to a baby or her sexuality. How do you deal with that when the breast turns on the woman herself?
Well, there are a lot of ways. I would say that as a breast medical oncologist, probably 90% of my time is spent in helping a woman through the diagnosis, through the difficult rigors of all of the different treatments, trying to help them to adjust to a new set of issues for them, helping them to adjust to the concept that this need not necessarily be a life-threatening problem for them. Because I have the time to spend with my patients, I spend a lot of time in psychosocial interaction. But still we need help occasionally, and sometimes more than occasionally. And there are those women who have very significant issues, either with body image or with depression, anxiety, and there we're fortunate in that we have a very good psychiatrist here in Deerfield that we work with, who helps us. In addition to that, we've also found helpful our integrative medicine program. Dr. Mehta trained under Andrew Weil, and he has developed a team of individuals, including an acupuncturist, a nutritionist, a physiatrist, helps with exercise programs, and massage therapy, and others will be built into the integrative program. He's also an expert in complementary therapies, because most of the women, whether they'll admit it or not, are taking some, or in some women, a huge amount of other things from health food stores. And no medical oncologist is schooled enough in these things, and so having someone like Dr. Mehta on board helps us to deal with that issue.
Very nice. Are there any support groups that you recommend your patients to seek out?
The one that we've used in our area is Gilda's Club. We would like to build up our own support groups here. Many other hospitals have support groups. Deerfield is a relatively young cancer center, and we have an excellent social worker who is helping to start some support groups. I think when one thinks of support groups, I like to see them developed for breast cancer in different stages. I personally don't prefer the support groups that just say this is a breast cancer support group, because therein you'll have women newly diagnosed who are facing very different problems from women with metastatic disease, virtually all of whom might be destined to die of their disease. So what you may find is that some of the newly diagnosed patients will come to the first support group or two and drop out quickly because they don't want to get depressed.
Right.
So I would like to see a support group for young newly diagnosed women, a separate support group for metastatic disease women, because I think that they come to the table with different issues.
Thank you so much. Thank you for watching. We hope this has been educational for you.